peer educators, all of whom report having had sex with both men and women. They have now been through 3 rounds of training and are very active. Why does this matter? I'm coming to the end. These projections were made as a result of modelling by the Commission on AIDS in Asia. The yellow part of the bars represents the projected proportion of new infections up until 2020 attributable to male-male sex. In the past, you see the dark blue bars were the biggest group. They were men who paid for sex. The green are injectors, but actually not relevant yet in LARS. So by working with these men, we can also influence their female partners with the so-called females who are not now in at-risk populations. I think the circle came around finally acknowledging that the earlier survey of young men found that unmarried men generally don't pay for sex. They find young female sex partners. So the Netherlands the UNFPA funded this survey, which found that around 20% of never married women had sex. Now that's much lower than in, say, Papua New Guinea, but in a country that values virginity at marriage, it did surprise the government. About a third of these women were having multiple partners. 3% of women had sex with another woman, which of course is a low-risk activity, and a very much lower proportion than men who had sex with men. We found that more than a quarter reported having been coerced to have sex, and their condom use rates were quite low. So we now have funding, this time from the Netherlands Embassy in Bangkok, for a young female peer educator program that will begin shortly. So finally, as we talk about opening up boxes, we seek to break down barriers. I doubt you'll see this football game or something like this take place in Faulkner Park. It's a football game between 2 teams, one of servicewomen or sex workers, and the other from the Vientiane Department of Health. And not that clear a photo, but I challenge you to tell me which team is which. Just for interest, the red team are the sex workers, and they lost the game. Also breaking down barriers between men. We supported inaugural, what's called a bisex football game. This is just 2 of the teams. There were actually 8 teams altogether, involving men of different sexual persuasions. You can see the cheer squad tends to be of men at a certain end of masculinity gradient. So, over the past decade, Burnet programming in low-income countries has resisted many of the commonly promoted paradigms that have guided and sometimes confused HIV responses. We've conducted context-specific social and behavioural research to characterise risk and vulnerability and use the data to plan programs and also help inform national, regional and global HIV strategies. We've not taken our eyes off the ball. Sex and drug use can transmit HIV, while many fashionable donor trends have distracted many others. Nevertheless, we do acknowledge the importance of addressing risk behaviour in an appropriate way, depending on the specific social, cultural, political, economic and religious context, and also to ensure that we address issues like stigma and discrimination that are major barriers to accessing information on HIV. We are, despite our 130 staff, still pretty small by global standards. So to maximise our impact, we engage in developing national, regional and global policies. For example, helping to develop Burma's new HIV plan, helping to develop ASEAN's 5-year work plan, and helping the development of national HIV strategic plans in 14 Pacific nations and a regional strategy. Consultancies can have a big impact, particularly this example of providing assistance to the development of national strategies to prevent parent or mother-to-child transmission in India and China, the 2 biggest countries in the world, Laos, Burma, Sri Lanka and Pacific countries. And finally, as Brendan mentioned, we teach courses on community-based HIV here in Melbourne every year, including harm reduction courses. Every year, somewhere in Asia, in Southeast Asia, it used to be Bangkok, now it's Phnom Penh, and starting next year we will have a course in Japan. So, thank you very much for the opportunity to give this presentation, and my apologies for going over time. I want to thank my fabulous colleagues and friends, only a few of whom are in that photo. Their support has been fantastic, and we could not have experienced the growth and success without such a special group of people. Thank you, David, for setting the precedent last year, also acknowledging my parents. Unfortunately, neither of them were well enough to come along today, but they're both in their 90s. Professor Fenner, my father, was born about 6 months before you, and about 30 kilometres away in Plumes, because I understand you were born in Ballarat. So thank you very much.
Well, thank you very much, Mike. And I think it just goes to show the incredible breadth of the institutes and our commitment to making a difference in infectious disease, especially, and health more generally. And we're very proud of the fact that we work right across the range of disciplines, from the laboratory to epidemiology and public health research and public health development, as you've really heard today. And we're extremely proud of that. And thank you again, Mike, for all your work, for a wonderful lecture today. But before you get that off, my notes do tell me that you're willing to answer a few questions, and I really hope the audience has some. And I was going to start off with one, if that's all right. No, I was thinking about something else, but so I guess you showed really very dramatically, especially in the graph of Thailand, the impact that condom use had on reduction in HIV. And I guess I'm thinking more generally then, what's the balance? What is going to really lead to the most dramatic impact, or at least even perhaps finishing off, you've convinced us that studies and implementation of policy changes of the sort we talked about today make an impact. What's going to finish it off? To what degree is new tools needed? Are we being distracted by the development of HIV vaccines and new drugs and fancy modern tools? And what's the balance?
Okay, there's no easy answer. I think, no, we shouldn't ignore the development of vaccines. We have to keep in mind the situation in sub-Saharan Africa, where countries like Swaziland, 40% of their adult population are infected, and people continue to be infected, and where behaviour change interventions have not been as effective as they have in parts of Asia. There are exceptions to that. There are countries like Senegal that's done very, very well. In Asia, I think it's very clear, and these are my own original ideas, from the epidemiology, we have to keep focusing on those three behaviours. Some people feel that there should be more resources into addressing, for example, married women, vulnerability of married women. We don't have an intervention. We can't go and suggest to married women that they tell their husbands to use condoms for the rest of their married lives. Perhaps in a country like Cuba, of course, tests everybody before marriage. I don't think that's yet feasible or even desirable in most countries. So we don't have an intervention for those women except to prevent infection in their male partners. And we saw the three ways that those men get infected: through buying sex from sex workers, from women who sell sex, from having sex with other men, and injecting drug use. The latter still in Thailand has not been adequately addressed, and is not a technical issue so much as an issue of being willing to put in place the policies and programs.